Good afternoon, everyone, and thank you, Bide sir, for always giving encouragement to youngsters like me. And no, दूसरा वाला, ये दूसरा है दूसरा. So I'll be speaking about the intraoperative PCR, how to manage it. ये बंद कर देना. मैं करूँ क्या? Yeah. First. Yes. Okay. So I'll be speaking about the intraoperative PCR, how to manage, and what is the thought process behind managing this. Uh, it's a not so rare complication, but I would say this is a complication where we can definitely give very good outcome to our patients if you manage it with proper thought process and proper steps. So, first thing to ask ourselves is that if there is a posterior capsule rupture, is it the end of the case? I would say the thought process should be it's a beginning of a new case. So think of it like you have a new case in hand, and how will you do it perfectly so as to give it a perfect outcome. So one thing you should understand, your plan should be always in hand. So don't be confused about the order of things. So the steps have to be done in this order. First step is to remove nucleus pieces if there are any. The second step should be to clear out the vitreous from the anterior chamber, and then the third step should be to remove the cortex. So I will go one by one and the steps which have to be taken in order to remove. So first thing is calm yourself. As I said, think that now you have got a new case in hand. Don't think about the first case where you were expecting nothing to go wrong, but think of a case in hand. So first thing is how to take the nucleus out. So we have two options. Either we can take it out through the scleral tunnel or through the corneal incision. Now through the corneal incision is easier to master if you are not used to SICS surgery, but again there will be problems such as you have to give very good sutures, and prolonged suture management has to be required to give a good refractive outcome in these cases. But the common mistakes which are done commonly when you are taking out the nucleus from the anterior chamber is that, suppose there is a 3 mm nucleus piece inside or 4 mm nucleus piece inside, you try to make the incision of the same size like 3 or 4 mm. It doesn't work because the nucleus is a three-dimensional structure. So always make a point, the incision size should be at least 1.5 times the size of the nucleus piece that you are going to remove. Otherwise, what will happen? There will be a lot of endothelial damage when you're trying to take out this nucleus. Now, this is another method which is used using wire vectis. But if you are using wire vectis, remember, use a sandwich method. That means you have to put it between two instruments. If you try to do it with single-handed, invariably what happens, this piece tends to rub against the endothelium and you have endothelial damage and edema postoperatively. Now it's easier to enlarge the existing corneal incision by using corneal scissors. Many times what surgeons try to do is they use the same 2.8 keratome and enlarge it. Most of the times it becomes more ragged than you want. So like the earlier ECC days, the corneal scissor works best. If you do it tangentially exactly, you get very good incision structure. Now in order to remove the nucleus, the most important tip to understand is that always push OVD from the deeper most part of the nucleus. This is, I think, again I will emphasize in another video, this is the commonly done mistake by surgeons. They try to keep the anterior chamber maintained because that is the your instinct. When you are doing cataract surgery, you try to keep on maintaining the chamber, and unfortunately they push more viscoelastic in front of the nucleus, or when they go behind also they don't reach the posterior most or deeper most part of the nucleus, and then you may have a situation where one of the nucleus piece drops down. When you have enlarged the corneal incision, make sure that you close that incision before you are going ahead with vitrectomy, because then you have a closed chamber, you have much better control on the globe, you don't have collapsing chamber anytime. So that works best. When you are doing scleral incision, sometimes you may not suture if there is no leak. Okay, always make sure, I think in vitrectomy part we have to make sure that pupillary contour, the contour of the PC rent and anterior capsule is also has to be properly seen. Now second part I am going to show converting into the scleral SICS tunnel. Okay, first thing, make the patient very comfortable. If you have a complication, just give a posterior subtenon block. It's very easy. First I think I will just re-show. First, just infiltrate the intranasal area with xylocaine. You can use just xylocaine, there is no need of sensorcaine. And then create, now I am infiltrating the intranasal area with xylocaine. Give 1 minute, then open up that space so that patient is comfortable, and then use a blunt cannula. You can use the visco cannula after removing the visco from that. Go behind and just give 1 to 1.5 cc of xylocaine. That's more than enough. Again, wait for a minute because it takes little time for the xylocaine to act. Don't just start hurriedly. Wait for a minute and then start making the scleral tunnel. Now, if you are well versed with SICS, then you are good to go with this technique, because here there will be some challenges, like there will be a little bit of hypotonia as compared to a routine SICS case, but you are well versed with SICS, you can do it really easily. Okay, avoid the area of initial incision, but if it is not possible, don't worry. Usually the corneal incision do not merge with the scleral incision. And always make a large scleral tunnel. Don't try to be meager in the size of the scleral incision. You can always suture it to reduce the amount of astigmatism, but you want a very traumatic delivery of the nucleus when you have a complication. Like for example, in this particular case, there is almost entire nucleus. So this was the case where there was a hydro rupture and we have to remove the entire nucleus. Now, best way to remove this nucleus from the back is either use this ball tip chopper and flick it above, or you can use the Tuschinski method, which I have not shown in this video, but that is also very nice technique to use those two Shinskis like chopsticks and just rotate it in front. Again, here the commonest mistake done is pushing the OVD over the nucleus. Here you want to hook and bring the nucleus up and then use the viscoelastic. Again, the same principle to remove this nucleus from the if in presence of rain is use the, see, just I wanted to show this. Look at the position of the visco cannula here. It is deeper most and posterior most when I start injecting the viscoelastic, and then at the same time you press the posterior scleral tunnel and the nucleus will come out very easily. This avoids nucleus drop as well. Okay, so using visco removal, good scleral tunnel and nice size scleral tunnel, it's very easy, and you have pristine clear cornea next postoperative day with very good vision for the patient. Now moving out to cortex management. Once the nucleus pieces are out, go ahead with cortex management, but always make sure there is no vitreous inside when you are removing the cortex. So first method is to use the vitrectomy probe itself to remove the cortex, where you can toggle between IA cut and cut IA mode. That means when there is vitreous, you shift to cut IA mode. When there is no vitreous, you do IA cut mode and remove that cortex. But there will be some issues for beginners when they are using this vitrectomy probe to remove the cortex, because vitrectomy probe generally has much sharper edges as compared to bimanual IA. So if they tend to go closer to the anterior capsular axis, they may have tears. Like in this case, the anterior capsule got torn. So it might jeopardize the chances of putting the IOL in the sulcus, or it may also cause dialysis if they are not able to control, because vitrectomy probe might be little bit difficult for the youngsters to control. So for beginners, it is better that you just initially maybe clear off the vitreous first, and then you can shift to the second method, which is using the bimanual itself to remove the cortex. Now, one issue in this case is that if you are not done vitrectomy properly, or during the cortex removal, if there is vitreous strand in between, you have to stop, you have to reflux, and then just change your the aspiration probe with the vitrectomy probe and cut that vitreous. Okay. And third important tip is to do cortex aspiration with cortex removal with dry aspiration, where there is just visco. So what happens is that initially when you are not used to vitrectomy and there is no vitreous, there is just anterior hyaloid opening there, sorry, the PC opening, but anterior hyaloid is intact. Whenever you start the irrigation, sometimes the anterior hyaloid opens up and then you have to do the vitrectomy again. So in these cases, the dry aspiration method really helps, where the anterior chamber is maintained much easier as compared to when there is fluid. Only thing you have to do is that you keep on supplementing this 2% HPMC every now and then you can easily remove the entire cortex with lot of time in hand, because you are not worried about the turbulence which may happen when you are using irrigation in the anterior chamber. So this is the third method to remove the cortex after a PC rupture. Okay. Now we'll move on to the IOL placement in sulcus. Of course, we have to place IOL. So easiest way to do is to do IOL placement in the sulcus. Of course, the 3-piece IOL are preferred. Now, one thing, once you migrate, you become better and better. You have to always think of your plan before. This is very important. You should understand whether you are going to do optic capture or not. That's because if you are going to do optic capture, remember that you have to use the same power which you have decided, the emmetropic power. Because if you are not going to do optic capture, you reduce the power by 5%, because ultimately you are trying to give the best refractive outcome to the patient. So simple tip is that. Now, for doing good optic capture, the size of CCC should not be more than 5.2. Ideally, is 4.8, and it should be central. If it is too decentered, just beforehand only decide, I'm not going to do any optic capture. I'm sorry. Pause there. Okay. So again, optic capture is to be done. Use the same emmetropic IL power. It will give you the best result. Okay, now this is a technique to show the optic capture being done. Now the commonest problem which may happen during this case, if you try to insert the IL directly into the sulcus, so avoid that. Always create adequate size of the incision, because this is a hypotenuse globe. If you have made very small incision, you struggle, you will have problems. So enlarge incision little bit, go ahead, put the Sinski under the optic as always, because you have already done a complication. Now you don't want the IOL to drop down into the you have already vitrectomized also, so vitreous is also liquid. You don't want that. So open up that 3-piece IOL in the anterior chamber itself, and then you can very easily push both the haptics into the sulcus without any complications. Okay, so always avoid the temptation to put the haptics directly into the sulcus when there is a rent. Okay, now to do the optic capture, again the CCC should be well centered. Now you go ahead with the vitrectomy probe, or you can vitrectomy probe and irrigation, remove the vitreous or viscoelastic which is there behind the optic, behind the IOL, and now you have to push this optic through the CCC margin. And the mistake commonly done is you try to push at the center. Don't do that. Push at one end first. So one side is first optic capture is done, and then you go to the second side, and always look for the spindle side. You can see here there is no spindle, that means optic capture is not complete. Now I pushed it. Now you see a nice spindle shaped anterior capsular axis, that means optic capture is complete. But still it is not over. Okay, you have to make sure there is no vitreous left there. And when you finish the case, even if there is little bit of AC collapse during finishing part, the anterior optic capture may get reversed. So always make sure that AC is maintained. If you feel it has reversed, you can again tap down the IOL so that you have a proper optic capture at the end of the procedure. After any vitrectomy procedure, make sure that the incisions are watertight, so you don't have any leakage, because you have already done vitrectomy. You don't want any leakage from the incision, otherwise suture. Now the last part is, can you place the IOL inside the bag? Okay, after having a posterior capsular rupture. Now you will say, why do you need to take these kind of risk when you already have 3-piece option available? Now we have other things to do, like you have multifocal EDOF, toric IOLs, which you need to place inside the bag even if there is a PCR. So let's start thinking whether we need to put it and how to put it. Now first thing to realize whether anterior hyaloid is intact or there is vitreous present. If anterior hyaloid is intact, you can just place the IOL nicely in the bag if there is enough support without doing anti-vitrectomy, but make sure there is no vitreous, because this is another common mistake. If there is a vitreous in the anterior chamber, some surgeons, what they do with the visco, they just nudge aside this vitreous and put the IOL in the bag. But if you have not done vitrectomy and you have placed the IOL in the bag, on table it may appear well centered, but invariably over a period of time it will decenter. So avoid this mistake. Now let's think, what is the exact part of the posterior capsule that is really needed for the stability of IOL? So if you see this central part, if it is absent, it doesn't matter. You can still place nicely the IOL in the bag. Just make sure the haptics are perpendicular to that. So in this case, it's okay. If you have a small peripheral PC which is rupture, which is smaller than optic, you can still place. But if it is a large peripheral rent, larger than the optic size, don't do that, because invariably over a period of time, the IOLs will decenter. Another option is in absent PC is to do reverse optic capture. Put the haptics in the bag and capture the optic in the CCC if the CCC is small enough. Okay, so I will just show few cases where the About the choice of IOL, so if you are going for plate haptic or 3-piece IOL, I think if you have not done a posterior capsulorhexis, avoid these IOLs because they have kind of springy nature and might extend the existing tear. But these other types of IOLs are quite good enough to be placed in the back. Now, if you can do a posterior capsulorhexis, really it looks very difficult, but if you when you actually do it, you will find that it's much easier than even anterior capsulorhexis. So once you have a posterior capsulorhexis done, you know that the posterior capsular margins are quite stable, and you can then easily place the IOL in the back. So even after doing posterior capsulorhexis, you have to make sure, just watch how I'm doing anti-vitrectomy. Looking at different marks there, you can see the posterior capsular range. You can see there is an indent, and once I cut it, it becomes rounding. So these are different signs of presence of vitreous in the anterior chamber. So you need not necessarily have triamcinolone all the time. You can see the different indications of presence of vitreous, and you can cut the vitreous completely. Again, while placing the IOL in the bag also, use the same principles. That means first open up this IOL in the anterior chamber, keep the Sinskey behind it, and then slowly nudge the IOL inside the bag so as to avoid any further damage to the posterior capsule. And at the end, after you have put the IOL in the bag, of course, if you have done posterior capsulorhexis, it's much easier to use your bimanual or coaxial. But if there is a posterior capsule which is torn irregularly, what I do is just do passive visco wash. That means just using the irrigating cannula, just remove as much as visco as possible. This avoids sudden deepening of the anterior chamber after you have placed the IOL, and that avoids sudden extension of posterior capsule. Now here the posterior capsule is torn, but anterior hyaloid is intact, and you can see the size of the tear is small. So I can place the IOL in the bag, and I can just do passive visco wash and manage the little bit of rise in IOP. Now, how to check whether anterior hyaloid is intact or not? Okay, so once the you can see the posterior capsule opening is there. Once you put visco in it, if you don't see any visco going inside the vitreous cavity, you know that the anterior hyaloid is intact, and you can take a decision accordingly. Okay. Thank you, sir. I think I completed.
Thank you, Dr. SOURABH, for an excellent video presentation.